I am Kyubo Kim from Ewha Women's University, Mokdong Hospital. I'll talk about the radiation after mastectomy. And radiation after mastectomy is called PMRT in English, which is an acronym of post-mastectomy radiotherapy. First, I'd like to introduce the radiotherapy statistics in Korea. Among all cancer patients, those who receive radiotherapy is increasing as time goes by. From 2011, we can see that about 27% are now receiving radiation therapy as of 2014. And you can see the blue curve, which is for the breast cancer student, and you can see that the absolute number itself is higher, and also the number of patients is increasing who have been treated with RT. And now we have a long history of radiotherapy for breast cancer. And the first radiotherapy for cancer has been conducted just 2 months after the X-ray has been developed. Mr. Emil Grubb has conducted the radiotherapy for cancer in 1895. After mastectomy, the local recurrence has appeared, so radiotherapy has been applied at that time. So radiotherapy and breast cancer treatment are very intricately correlated. And this slide has been introduced in the previous presentation. In Korea, the breast cancer surgery statistics are mentioned here. The pink line represents the breast conserving surgery, the BCS, and the blue color, or the purple color, represents mastectomy. So about 1/3 is receiving mastectomy, and 2/3 are receiving BCS. And recently, the early breast cancer are diagnosed, and then they go through BCS. That is the increasing trend. However, still, if there is progressive cancer, advanced breast cancer, then there are still mastectomy undergoing in that case. Now let's look at the photo. The lower two photos are BCS examples, and the upper two photos are the mastectomy examples. And on the upper left hand side, you can see that the muscle, the large muscle, is also cut out, so eliminated. So functionally and aesthetically, there are some unfortunate events. So that's mastectomies, and that is not total mastectomy, and that is not conducted often these days. And these days, the BCS are conducted more often. So the right-hand side is better. The muscle is conserved on the right-hand side. And recently, if we say mastectomy, most of them are referring to the upper right-hand side type of surgery. Now let's look at the picture. So when we say mastectomy, it is about eliminating all the tissue of breasts, and under the skin and the muscle in front of the muscle, the tissues are all eliminated. But then, after mastectomy, there are patients who receive radiotherapy, and they ask this question: I have eliminated all my tissue, but still, do I have to worry about recurrence, and do I have to go through radiotherapy? Well, the tissue has been eliminated, and the muscle pectoralis major have been eliminated, but still there may be cancer cells right beneath the cells. It could be hidden behind the muscle pectoralis major. So, and if they proliferate, then that could trigger local recurrence. So even if you have gone through mastectomy, there could be local recurrence. So in order to reduce that possibility, radiotherapy has to be conducted. Now this is the outline of my presentation, and so I have mentioned that additional radiotherapy can be required. So who may benefit from PMRT? So in 2001, at the radiology clinical tumor society in the U.S., they have come up with a guideline. The ASCO has come up with a guideline. They have gone through and reviewed the past studies and have presented the following guideline. First, they considered tumor size. If the tumor size is larger than 5 centimeters, and if the axillary contains more than 4 lymph nodes, then additional therapy, the radiotherapy, is required. And then let's look at the third item. If the tumor size is 5 centimeters or less, and if there are 1, 2, 3 involved lymph nodes, then that won't be a clear decision. So there's insufficient evidence to make recommendations or suggestions for the routine use of PMRT. So evidence is not sufficient. So this stays in the gray zone. And then in 2014, as Professor Kim has mentioned, there have been an analysis that was published which combines previous researches. First is a group that hasn't gone through radiotherapy after mastectomy, and the other has gone through radiotherapy. So the ones who didn't have metastasis in the lymph nodes, for those, the recurrence or the mortality rate had not been different regardless of whether they have gone through radiation therapy. However, if those who had lymph node metastasis, we can see that there are a difference in these two curves. And if you have gone through RT, then the mortality and recurrence have gone down. And I've mentioned the gray area. So those who have lymph node metastasis on 1 to 3 nodes, then in this case as well, the RT benefits the patients in terms of recurrence and mortality. Both have gone down. And that has been confirmed in the 2014 study. So the ASCO and the ASRO and the Society of Surgical Oncology have come together and discussed further and updated on the gray zone cases. And they have presented it. Well, still, it's in the gray zone. But if we go to the details, then we can see a difference in a very delicate way. Well, between 1 to 3 metastasis node, then part of those groups, we can say that there may be RT benefits, but we cannot select which ones that may be because there were not any evidence sufficiently provided. That was the previous guideline, but now it is different. The RT is beneficial. Of course, not everybody will benefit. There may be adverse events for people. So those we cannot differentiate between those who will benefit and who will not because of adverse events. So in the past, there were some positive notions, and this compared to the past, now we have some positive notions, but still we cannot distinguish clearly who will benefit and who will not. So what is done in Korea? In Korea, there is a guideline as well. The surgeons and the tumor-related surgeons and the radiation department and the imaging department, doctors come together and discuss what kind of guidelines should be provided for breast cancer. And here we have the Korean guidelines. So depending on the number of nodes, the guidelines are presented. So if there are 4 or more nodes, then RT is recommended as necessary. And if there is 1 to 3 nodes metastasized, then strongly consider is presented and recommended. And then third is when there is no lymph node metastasis, there may not be benefits with RT, but if we look into some more details, there are some subgroups who would benefit. Well, this is too complicated, so I would like to move on to the next slide. So who should be treated and which areas should be treated? So Professor Kim has already mentioned, if you have cancer in the breast, then metastasis may occur to lymph nodes, and that could be for the axillary. And if there is axillary lymph node metastasis, then along the node, then there could be metastasis in supraclavicular as well. And depending on the location of the cancer, then there is the lymph node as well, another lymph node, and there is a supraclavicular, then there is a lymph node near the pectoralis minor muscle. So there are 3 types of lymph nodes, and there could be metastasis in these areas. So if you have these metastases, then that could happen. And there has been co-research that have happened in Korea. So on the right-hand side, you can see the mastectomy, and there was a recurrence, and the site of the recurrence for the patients have been marked. The red color is the axillary lymph node, and upper we can see the supraclavicular lymph nodes. So those are marked. So those are very densely located, and the blue line, we can see the long line, and then there are less dense recurrence happening here in this part. And then you can see that at this place where the mastectomy has been conducted, still recurrence can occur. So when we do radiotherapy, we check the location where the breast has been present, and then we also look at the supraclavicular lymph node and the internal mammal lymph node. Mammary lymph node. So according to the Korean guideline, we can see that if there is 4 or more nodes metastasis, and if there are 1 to 3 nodes metastasis, then RT is strongly considered. And also we have to see the locations where the breast has been present. So we look at the chest wall, axillary, supraclavicular, and internal mammary nodes as well. Of course, the internal mammary nodes is not a place where metastasis happens often, but still we have to consider whether RT is a must for this location. Do you have evidence? Well, we do not have sufficient evidence for that. And let's look at this picture. There was a left breast mastectomy, and in the sternum, if we go to the internal mammary lymph node, then if we do the radiotherapy, then the heart can also be affected by the radiotherapy, and the that then adverse events could also happen. So we have to consider all these impacts in order to define the area, the size of the area. We have to consider the benefits of radiotherapy and consider whether the recurrence can be decreased significantly. And also we have to consider the adverse effects that comes from treatment. We have to reduce the probability of recurrence and also reduce the adverse events as well. I have mentioned the internal memory lymph node, but then the RT benefits for this area do not have sufficient evidence, and also we have to consider the adverse events. So we have to go through more studies on that. And there have been joint researches going on in Korea as well. So I hope that there will be good outcomes coming in the future. So after going through total mastectomy and when there is radiotherapy applied, then we may also have to consider whether internal memory lymph nodes should be good for receiving radiotherapy. But if we have this study result and we have sufficient evidence, then we will be able to make decisions more easily. Now let's consider PMRT after preoperative chemotherapy. When the tumor size is large and if metastasis to lymph nodes are suspected, then chemotherapy is given before operation. But then the tumor size may grow smaller. But then after going through surgery, the lymph node metastasis could go away. In that case, what kind of RT and in what way should be provided? Those kind of things should be considered. The previous cases were about lymph node metastasis that have actually happened. And after operation, if there is no longer lymph node metastasis, do we still have to go through radiation therapy? So let's look at the Korean guideline. So if there has been chemotherapy before operation, and then we have to decide whether radiation therapy is needed, then we have to discuss the pre-therapy clinical stage and pathologic stage as well. And we should see the maximum stage from the pre-therapy clinical stage and pathological stage. At diagnosis, we saw the lymph node metastasis, and then after operation and chemotherapy, the lymph node metastasis has been eliminated. But still, we have to base our criteria based on the diagnosis at the clinical stage. Pre-therapy. So let's look at the NCCN guideline. So at diagnosis, if there has been node positive, and after chemotherapy, if it's node positive, then PMRT is recommended. And then at diagnosis, if there is node positive, and after chemotherapy, if it is node negative, then PMRT can be considered strongly. But then at diagnosis, if it's node negative, and after chemotherapy, if it's node positive, then of course you have to go through RT. And if there is node negative, and if it's node negative even after chemotherapy, then no PMRT is recommended. But clinically, there are a diverse array of cases. And recently, HER2 positive and chemotherapy and targeted therapy are given before operation, and mastectomy has been applied, and all cancer cells have disappeared. Then do we have to go through RT? Well, there may be many different opinions and controversy, and this is also a major research topic internationally, and a large research and study has been conducted. So when we see the outcome of this study, then I think we will have a more clear line drawn. Now let's talk about PMRT after breast reconstruction. In terms of breast reconstruction, we can see different types. It could be using your own tissue. It could be using the other, and then there could be also prosthetics used. And even if you're using your autologous tissue, it could be further divided into subcategories. So if you look at the statistics in Korea, the number of breast reconstruction is increasing, and the breast reconstruction is now covered under insurance. So I believe that more patients are choosing to go through breast reconstruction. But then we have to consider whether RT is needed. So in that case, breast reconstruction does not affect our decision. When we make the treatment decision, we base on the cancer stage. But then there are some concerns. Adverse events will be mentioned later on. So if you are using implants and doing breast reconstruction, then you go through radiation therapy, then you will experience capsular contracture in some cases. So the implants shapes could also change. So in that case, we have to consider how we can reduce adverse events for these type of cases. And some studies are underway to resolve these issues, and there are different types of RT, 3D RT, and many other types of RTs. So those studies are underway, and if we have more data, then I believe that better RT approaches can be provided. So that's all I have, and thanks for listening.